All right. Thank you everyone for joining us today. We have a few things to talk about since the last time we met. First things first, we are so happy and lucky to have Kate Hill with us today. She's going to be presenting on chronic disease management in an outpatient setting, along with PCMH best practices. But before we jump into that, Mr. Greg Wolf will be giving us an update. I know I send a lot of emails, and we've received a lot of information about all of the different funding mechanisms that have been coming out. And so Greg's going to take a few minutes just to kind of explain which ones we have to apply for, how we spend the funds, and then some ideas for spending funds. And then as you probably heard us chit-chatting, we do want to be wrapped up well before 1 p.m. Central to allow everyone ample time to log on to the No Sort call, where they'll be providing technical assistance and more information about the Vaccine Confidence Grant. So with that said, I will turn it over to Greg.
Thanks, Laura. Yeah, this is Greg Wolf from Stroudwater, and I'm joined by my colleague, Jonathan Pattenberg, also from Stroudwater, and Kate Hill from the compliance team. And together, we're working with Laura and Pete and Corey at the state office to start putting in place the foundation for a statewide rural health clinic performance improvement network. And it's very exciting, and we're starting to see at long last a handful of states like Oklahoma be innovators around focusing on rural health clinics, and not just necessarily the community health centers or the hospitals. We think the RHCs are an incredibly important component of that rural healthcare safety net, and it's great to see that we're continuing to move forward and providing resources to the rural health clinics. Before Kate starts off with the planned content for this webinar, which really centers on chronic care management and on the PCMH model, I did want to take just maybe a minute to give a little speech, if you will, about what's going on nationally and perhaps even at a policy level. For the last 3 decades, during which RHCs have existed as provider types in rural America, there has been at times almost desperate need to find ways to allocate additional resources to support those clinics. We are directly today in the midst of a once-in-a-generation opportunity where there are funding opportunities specifically for rural health clinics. There is a growing concern, I think it's a legitimate concern, however, that rural health clinics are not availing themselves of these funds. That has the potential to create 2 really counterproductive results. Number one, a lack of resources, funding, dollars for rural health clinics to do innovative things, especially in the context of COVID. Most rural health clinics have been really hit hard as a result of COVID, whether it's units of sick patients or reduced volumes or just the operational chaos that hit rural health clinics. The second, perhaps longer reaching negative impact is that the Federal Office of Rural Health Policy, which has worked incredibly hard to make the case for these grant funds, that if clinics do not apply for the funds or don't use the funds that they already have, then the next time we have a need like we have found under COVID, the Congress will say, I don't think so. We offered you funding last time and you couldn't even accept the funding that we offered you. So we are in a critical moment. We are less than 2 weeks away from the deadline on the first of the major rural health clinic funding opportunities. It probably on average $50,000, but depending on the number of clinics that apply, it could be more like $80,000 per rural health clinic site for the Rural Health Clinic Vaccine Confidence Grant. And that's the one that you need to apply for. And nobody's looking for extra work. And yes, it is a HRSA grant, and therefore it's tedious and it's administrative, but we're talking about $80,000. And while it is purportedly competitive, there is widespread understanding that anybody who successfully gets their application in will get $80,000. I have not met a rural health clinic that could not use $80,000 free of charge. So that's the first one. That's the deadline. If you have not already applied, please find the time and the staff and the expertise, work with the state office or NOSOR or NARC, get your application in. The second,
Greg, can I just interrupt you right there, because that was well said. But here's when Tom Morris calls Kate Hill, I'm like, oh my goodness. And here's what I would do tonight if I was one of you. I would get on the government website and get my DUNS number. That is the hardest part of this. He basically said these words to me: unless you write gibberish, you will get this money. And that's the easy part. The hard part is getting that number. So that's what I would do first. The rest is piece of cake. So he says. So that's yes, what you got to do. That's really important.
Yes. And clinics, you don't have to know exactly what you're spending it on. You Correct. Don't need to have purchase orders waiting. Just get the money, and then you have a period of time to figure out what you want to work on. But don't leave money on the table. You won't get it again if you don't take it. Thanks, Kate. The second piece, and it has two parts. One is the hospital part, and the other is the rural health clinic part. The hospital part comes through an existing federal grant called the Small Hospital Improvement Program, or SHIP grant for shorthand. Sometime later this summer, maybe as early as July, probably August, every rural hospital, so that's a rural hospital with 50 or fewer beds, will get $230,000 to work on COVID mitigation and prevention activities. If anybody's been paying attention, every rural health clinic site last week already received $100,000 from the federal government, free of charge, to work on COVID mitigation and prevention. If you don't use that money, you will have to give it back. You need to use that money, not today, not tomorrow. In fact, you have almost 18 months to use it. But we need to start working together in Oklahoma as a community of rural health clinics to work together on those things we want to focus on to make the rural safety net in Oklahoma as strong as possible by having great clinics and clinics that are prepared for the next pandemic. So that's the speech. I know you have patients to take care of. I know everybody's busy. This is a big thing. The next 5, 6, 10 business days, work on your grant, get the money, and then we can figure out what we're going to do with it. So Laura, is there anything else you want to say as I've now beaten the drum for 10 minutes?
No, I know that I heard from several folks last week about the $100,000. This is really for the folks who have multiple RHCs. Go in, double check that your amount is correct, because if it's not, please let me know as soon as possible so I can reach out to our technical assistance folks so we can work with them to get that resolved. But please go in, double check, make sure you got it, and also make sure your amount is correct. And that's all I have.
But ask people to be paying attention and start connecting dots, because you may be thinking, well, wait a second, I have $100,000. Okay, I got to do something on COVID. I've got 18 months. I can think of a bunch of things I'd like to do, but we don't really have a plan, perhaps. Or maybe we want to hire somebody. Can we hire somebody, et cetera, et cetera. Kate's going to walk through the chronic care management process, but then she's going to quickly link it into a program that we think makes incredibly good sense that fits with the grant guidance. So if anybody's wondering exactly what they can and potentially should be spending their dollars on, please pay attention to what Kate's going to present, as well as Jonathan. So with that, Kate, I'd like to hand this off to you.
Thank you. And a great start here. So we're going to talk about chronic care management. We're going to talk about a PCMH model with COVID, and then the hospital grant opportunities, which we actually just did. So for the COVID, I asked Tom if hiring a care coordinator for your patient-centered medical home who will focus on disease management, EID, emerging infectious diseases, would qualify? And he said, yes. So there's a hire right there. We're trying to all be so creative. So why now with PCMH? Well, it's always a good idea. But right now we have plenty of funding and you wouldn't have to pay for it, which is a really good idea. So HRSA has asked us, as I said, I got a call from Tom myself, to talk with the states about using that money. And it is a use it or lose it situation moving forward. And PCMH with COVID is one way that you can do that, because that's why we added this module in there, if you will. And so with that, I wrote the three, because Jonathan is the expert on the billing side of things. I wrote the three CPT codes that are the most used with chronic care management, 1, 2, and 3. You'll have these for study, and who is eligible to do chronic care management, which is all a part of patient-centered medical home. And with that, I'm going to give it back to Jonathan to talk to you for a minute, and then I'll move forward. This is a very long link. This is to the MLN. And if you don't know about those, Medicare Learning Matters are wonderful. Give all the facts to the one at the federal government for chronic care management. So Jonathan, go.
Thanks, Kate. So when we talk about these different opportunities, what we really want to look at is partnering with rural health clinics and looking at how to expand access to care and looking at these different services. We want to create an environment where it's low risk from a perspective of entry. And what I mean by that is what we don't want to do is go into something that jeopardizes the future financial solvency of the organization or puts us in a tenuous position where we're unable to sustain those services or unable to actually provide that care going forward. Now, with that material change in the RHC reimbursement methodology going forward, we definitely want to take into account how we are playing and how we are factoring the ability to provide these different services going forward. Now, at a high level, rural health clinics are able to provide the transitional care management, chronic care management, the principal care management, which is actually new to the program, the behavioral health integration, and the psychiatric collaborative care. I'm going to spend a few moments just talking through the differences between these, but it's important to note again, even if we are an independent rural health clinic or we're in a system relationship, it affords us the ability to look at how we can leverage these different programs to really start to improve the continuity and the access of care. And again, especially because many of us are in rural environments, we want to take into account and afford ourselves of every opportunity to improve the wellness of the patients that continue to come within our environment and within our clinic. So the first one is transitional care management. And this one is really affording clinics the opportunity to provide transitional care services to patients that recently had an inpatient setting or inpatient visit. Now, oftentimes what ends up happening is many patients that end up having an inpatient admission and they're eventually discharged to an outpatient setting, many of them have a recurrence of events or end up getting readmitted because there is not that individual to continue to focus on and discuss things in an outpatient setting. So when we look at those transitional care services, it really focuses on that face-to-face service or having those discussions in a 7 and 14-day time frame from discharge. And it's really looking at things such as medical reconciliation, education, reestablishing referrals, and again, really to ensure that they continue to get that care in that post-inpatient setting. Next slide. Now, chronic care management is really around working with patients that have 2 or more chronic conditions. And again, similar to the transitional care management, it focuses on the management of medications, appointments, service management by one health provider. Now, one of the key distinctions is that a provider can receive payment for CCM when they conduct at least 20 minutes of qualifying CCM services within a given calendar month. Now, again, if these numbers drop in 1 month, you do 18 minutes, again, that would not qualify as a billable visit for the CCM services within a given month. And again, it can include management of care across providers. And as we talk through these things, really the goal is to increase the continuity of care, the access to care. As many of you know, our healthcare environment can often be very complex, cumbersome, and obviously confusing. So what it does is it puts them in contact with a care provider that can help them work through the nuances of those programs. Again, because oftentimes patients may get services at your facility, but then they'll go see a specialist or go see some other care provider. Again, it's really working with them to manage those chronic conditions within that environment. Next slide. Next is principal care management. Now, principal care management is very similar to the chronic care management. However, this one is limited to a patient with a single high risk or complex condition that is expected to last at least 3 months. Now, whereas the last one, that chronic care management required 20 minutes of service, this one requires 30 minutes of service within a given month for it to be billable as a qualifying visit within the RHC. Again, it's something that does require a good amount of attention and working with that patient to end up resolving many of the issues. But again, it's looking at from the perspective of how can we improve the overall outcomes for that patient. Now, again, just to emphasize, this one was recently added as an allowable service within the rural health clinic. I believe it was added within the last 3 or 4 months as a service that does now qualify as something that can be done through the rural health clinic program. Next slide. Now, the last two that I'm going to talk about from a chronic care or at least the care management services focuses on the mental health side. Now, if you look across the country, there is really no clinic or no service that has an abundance of mental health providers. In fact, what happens is many times because of a low number of providers or the inability of patients to receive access to care for mental or behavioral health conditions, oftentimes it is our primary care providers or the emergency room or other locations that are having to provide this vital resource due to the lack of these services that patients are able to get. Now, in a behavioral health integration approach, again, another one that is allowed within that rural health clinic program, it focuses on a team-based collaborative approach. And again, this is something that also requires 20 minutes of qualifying BHI services within a given month to be able to qualify for a billable visit with that time. And again, it can include your initial and ongoing assessments, care planning, facilitating and coordinating treatment, and continuity with a designated member of the team. Again, really working on the outcomes based and really focusing on when we look at healthcare environment, the United States healthcare system is very much focused on a sick care type model. Those patients that present because something has gotten to the point that it can no longer be managed without actually engaging a provider. Many of these programs really take a proactive approach and allow you to start to dabble in those things such as population health or risk-based outcomes, or really focusing on transitioning from that risk sick type model more to a true health outcomes-based model. Next slide, Kate. Now, the last of the chronic care management is really around your COCM. And this is a psychiatric COCM, which is really focused on a provider that's of primary care, providing those core services in conjunction with a psychiatrist. And this is one a very involved, very labor intensive environment when compared to the other ones. This one requires 70 minutes within that first month and at least 60 months thereafter be able to continue to bill as a COCM. Now, one thing I wanted to note also is a lot of the administrative functions, just the taking notes, transcription, all of those things, that does not count under COCM as actual services that qualify from that perspective. It really has to be patient focused, the services that you're providing to be able to bill under a COCM model. But again, all of these different ones, and it's not to say you have to do all 5. You can do 2 of them. You can do 1 of them. You can do 4 of them. You can do all of them. It's really evaluating the needs within your given community to ensure that you're providing the services that they need from that perspective. Next slide, Kate. The last is really your patient-centered medical home. And Kate can talk 10 times more in detail about this than I can. But at a very high level, when we look at our PCMH, what I want to focus on for a second is really an approach from a methodology perspective. Not necessarily the certain benefits that you would get, but PCMH is really an approach. It's an approach to the delivery of care, of creating that cohesive environment where patients will have that direct relationship with a provider who coordinates the overall team from a healthcare perspective. And it's really taken that team approach that allows you to really start to work together to those improved outcomes. Now, Medicare and Medicaid programs have provided different opportunities There are oftentimes many commercial payers that will pay you an additional stipend, whether it's a PMPM or what other type of reimbursement, as a means due to the beneficial outcomes tied to an overall PCMH strategy. And when we look at that PCMH strategy, it's really to make primary care more accessible, to be more supportive, to really work with the patients to get through that healthcare environment. I know I've gone through a lot of this information very quickly. And again, if there are specific questions, please don't hesitate to reach out to any of us. It was, again, just to increase some of the awareness around some of those different opportunities that you can take relative to either care management services or the PCMH program as a whole.
Excellent. Thank you, Jonathan. Very good. So let's talk really quickly. We're going to try and give you time to log into that big webinar in an hour, so less than an hour now. So we're going to give you a lot of information that you can read later. All right. So there's no problem. So when you sign up to be a patient-centered medical home, the whole clinic is evaluated. And those are some of the all of the subjects actually in the basic PCMH. But why add COVID? Well, I think we've heard, I don't need to read this again, but we've heard that there's all this money out there. It also says a lot that what they think might happen again or in the fall, like flu, it's going to come back with a vengeance, whatever. We need to be prepared, which is why, by the way, I asked Tom why we couldn't delay that date. And he said, no, we need to be ready for fall. And so I didn't get into it, but that very well may be the reason. So that's why they wouldn't extend the date, because everybody's on such a short timeline and you're all so busy. So your projects that you spend this money on must be COVID related. So adding a COVID module to the PCMH project is the perfect solution. So in response to that federal funding, that's what we did. We came up with the COVID medical home. Now, if you are already a patient-centered medical home by any of the other vendors, you can just get the COVID module and again have that paid for by this federal money. So it really it's going to work for everybody that's listening. So I'm going to run through these really quickly. We made them EID standards based on the new Appendix Z. If you haven't seen that, you need to call me. We'll talk about it. Based on emerging infectious diseases. So it may not be COVID, it may be something else. So we're going to say EID. So written description of the scope of services that you offer. If you get a quick read on these, you're going to find you're already doing most of this. So it's not going to be a terribly heavy lift. And if you don't know the compliance team, most of you do, but if you don't, this is what we do. We work with you through the process to get it down for you. And then somebody else comes and does the survey. Somebody from our organization, of course. And there's a process for the entry, receipt, and disposition of your orders for your point of care COVID testing. There's a quality control plan for testing. Obviously, you would have that. So you see, we're just taking all that you're already doing and solidifying it and giving it meat to it so that you can put this, whatever we come up with, where this is moving so fast, we don't even have that seal or logo or whatever it is that says to your community, we are COVID educated, if you will, and aid in getting your patients back to you and in instilling confidence in your community for COVID. EID 4 instructs the patients on testing and collection procedures for emerging infectious diseases. 5 is all the testing equipment and everything is stored according to manufacturer's guidelines. That's a standard in all standards. And so that would be expected to be there. Nothing unusual there for you though. EID 6, establishing a vaccination program for staff and patients considering or receiving an emerging infectious disease vaccination. And so there's the teaching at a minimum about vaccines, preventive measures, treatment, transmission, and the impact of infectious diseases like we've seen with COVID-19. 7 is your quality control program. Of course, you have one. And 8, they're stored and handled according to manufacturer's guidelines. And that's been changing. Even the low temperature one doesn't need low temperatures anymore. So things are fluid at this point. Boy, if you don't pay attention, you could be behind in about 2 days, I think. EID 9, a process to implement community mitigation strategies. So this is what we really want to focus on. This is what the federal government wants you to focus on. How can we get involved in the community more? How can we stop the spread when it happens, if it should happen again? Boy, I hope we never need any of this, but that's not how we're looking at it today. We're preparing for the worst, and preparation, of course, is good. That's always good. 9 continued. There's a whole lot in 9 because it is about mitigation, and we need to have that. Collaborating with your businesses, your schools, other settings in your neighborhood. The faith-based organizations are very, very big place to go. That if it comes from the pulpit, people tend to believe, or not, whatever. We won't go into that today. PCMH. So these are the patient-centered medical home basic standards. Again, you are already doing that. And I will say this, every clinic that comes to us who's doing chronic care management, which Jonathan just covered, is well ahead of the game because the elements are there. You have to do a care plan for those patients. There's a lot of structure to that. So I don't want to go too fast here, but I do want to leave time for questions. The organization utilizes a PCHM. That's just what we call our care plan because you all have a different definition of care plans all across the country. We found that out very quickly. So ours is just our own name for a care plan. That's all that is. But it adds some different things. 3 is tools. And I just threw a tool up here. You use tools to educate your patient. You probably use some CDC tools right now to educate them on COVID. And that's the whole point of PCMH 3. 4 is advanced access and community resources. So this is the one where you give advanced access to your patients beyond your normal hours, and you start keeping your patients out of the ED. That's what gets the attention of your payers, especially Medicaid. And they're very, very good at giving a PMPM. Now, not every state does it. We would have to work with Oklahoma, but the more clinics we have in the program, then we have something really to go and tell them on the money you're saving them. You've invested. You've got advanced extra hours. You've got extra staff. You're answering every phone call, following up on everything, as you'll see in a minute. 5 is follow-up. This one clearly became a winner as we developed this program a few years ago, because we start following up on everything. And then we get more involved in these folks. They get healthier. They get more preventive medicine. We hit population health hard. Lots of things throughout in follow-up that's by your care coordinator or patient navigator, whatever you wish to call that person. This is the other big one for the payers. You meet the needs of your patients when you're closed. How do you do that? Do you have a care line? Does somebody assign to answer the phone 24/7? How do you manage that? No, there's no rigid way to do it. You come up with a way that works for you, and very, very important to handle that. So they don't go to the ED for something that isn't an ED visit. There was just an article today that came across the wires earlier that one of the big payers is going to stop paying ED visits if they're not urgent. Now that's scary because they're going to decide that instead of you on street feet, boots on the ground. And that's very, very challenging. 7 is unnecessary utilization of services, avoiding those ED visits, reducing hospitals, and having same-day appointments. Very, very important. And so we're going to teach our patients, and you think they know, they don't know. Some of them don't know. What is the emergency department for? And we're going to use tools like this to tell them, it's for heart attacks or suspected heart attacks, broken bones, major lacerations. It is not for sprains, strains, earaches, and sore throats. So it's really definitely an education process, and it will cut your numbers. PCMH 8 is that your health records are complete, and it adds a few things. We're going to do that behavioral health screening. We're going to find that depressed patient early. We're going to do the cognitive health screening for people over 65 unless there's symptoms before that. We're going to look at preventive health measures. We had a cumbersome system, and I can't wait till Greg starts because we changed that system, partnering with Pond to get a better way to make things happen rather than just reporting numbers. There's really just no point in that. So we're really excited to share that. And you're actually the first group, I think, that we're going to share that with. An after visit summary, critically important. What happened at that visit? Not all of us remember. I have a brilliant husband who forgets what the doctor said. He's an engineer, but he forgets. So I like that summary because I read it because I didn't go with him. And I can see, oh, we're stopping that, we're starting that, whatever the process is. So where to begin? And believe me, that was the quickest run through of standards I've ever done. But you can all have the standards if you like. We'll send them out. You can study them at your leisure, but we got to do something now. So we just completed step 1. So review your checklist. You will get a checklist to keep you on target for every program that we have. That's how we we do things, identify the gaps, highlights what's needed, review the policy checks section, make sure you have them all, and on and on and on. What do you do well already? And I know you do a lot of things well, so we won't belabor that. And it's a team project. You do need a champion. Look at your workflow, find out who the person is who's going to be your champion. Use your huddles for that. Get it out there and figure out what's the best way we can move forward and who's going to be our rah-rah person, if you will. So the champion is critically important. I won't spend more time on that today, but it's really, if without one, everybody's just complaining. So, and we're good complainers. We're really good at that. Hopefully less of that this year as we learn to deal with change in a most convincing way. So remember, patient-centered medical home is not a journey, it's a destination, and it's quality improvement over time, but you have to start somewhere. You have to start. And the primary care team is essential throughout this whole country in providing comprehensive care and focusing on what matters most to your patients. And that is really an important part of the program as we go. There's a checklist, you'll have that. You have a policy checklist just for policies, and on it goes. So some quality data ideas: readmissions, disease management of all sorts, health literacy, medication management, on and on. If you haven't been paying attention at NRHA, there is a push to get Congress to relax the cap for you provider-based clinics in trade for quality measures, which are all in this program in patient-centered medical home. So you're not only using the money wisely, one step ahead of the game in getting this done before it's required to get rid of that cap, which we hope. So this is just one hospital. I always love good examples. They identified 55 frequent flyers of their clinics, 7 clinics. These 55 patients use the ED for everything under the sun. And they really worked hard to establish the connection with the 55 patients. So this was the follow-up, call and call and call, bring them in, bring them in. We didn't change that behavior overnight. They came into the office, and guess what? Our own visit numbers went up. Well, an amazing thing. And the payers love that. We're a $200 visit instead of an $800 visit at an ED. Very, very important. And then in April, after they did their analysis, only one of those patients had returned to the ED visit. It was amazing. It was an amazing process. So we have a system for patient experience. We can talk about that later. It benchmarks. If you want to be better, ask your patients what you need to do. You do a great job, but what is the thing you could do better? And then we're going to turn it over to Greg.
Thanks, Kate. Next slide. So, Kate, thank you very much for that. I'm exhausted.
Me too. Me too.
That 25-minute sprint. I don't know that I've heard somebody not breathe, take a breath for 20 minutes straight. Oh, that's great. Let me try to wrap up with just a little bit of background on what makes this program a little bit different, we think better, and something that consider, whether it's with the
Greg?
Hey, Greg, we can't hear you that well.
No, you're not at all.
All right, I guess I'll jump in as Greg number 2 until he can get back on the webinar. So as Greg was mentioning with regard to data fatigue, is when we start to look at the information and start to focus specifically on performance improvement, what becomes fatiguing is really how we are going to leverage all of the different data that we have available to us. Now, looking at the available data and then actually leveraging and basing outcomes on how specifically to leverage that data are completely 2 different things. And oftentimes just figuring out how we're going to look, sort, report, analyze, and so forth, we often get overwhelmed with how specifically we're going to look at that data. So again, to have a system that allows us to functionally approach the use of that data to really drive evidence-based outcomes and really focus on performance improvement, it helps accelerate the position that we're in when looking at specifically the data itself. So by, again, reducing the amount of time necessary to have to focus on leveraging and looking at all of that different data, it allows us to focus on actual performance improvement going forward, which is really where we should be focusing on organizations as we continue to look forward.
Jonathan, this is Greg. Can you hear me okay?
I can now. I just jumped in for you just to
Thank you. I have no idea what happened. I didn't move an inch. Thanks, Jonathan. Kate, next slide. All right. So when we thought about all the tedious, time-consuming efforts that go into collecting and reporting the data, we challenged ourselves to come up with something that was really quite different, a redesign of how we deal with data. Because nobody wants to spend time providing data just for the sake of providing data. Nothing ever gets done with it. So the approach that we came up with, it had to be easier and save time. But what we're trying to do is to focus on work. Let's identify something that we want to change or improve. Let's put together a team and let's actually get something done. Let's not just keep looking at data and reports just because we're supposed to be looking at metrics. That's not particularly helpful, and quite frankly, it's not a lot of fun. Next slide. So what we've done is we've adopted the PDSA methodology. Most folks are familiar with that. The gold standard really comes out of the Institute for Healthcare Improvement and their model for improvement. What we want to do is we want to help clinics that are pursuing PCMH. We want to help them de-emphasize the tracking of individual metrics that you might see in a piece of paper on a report, but instead think about quality improvement and performance improvement as initiatives, work that gets done to improve the healthcare that you provide to your patients, or the engagement you have in your community, or how you can help providers work better with their clinical teams and with their patients. So the PDSA methodology is great because you come up with a plan, you actually spend some time doing some work, looking at setting up tasks and observations in a rapid cycle environment. Then you consider whether or not there actually was an improvement. Did something change? And then if something changed and you had a good idea, how do you spread that somewhere else within the hospital or within the clinic? And so what we've come up with is a methodology to have the PCMH clinics spend far less time tracking numbers and metrics and data, but instead working together on projects and seeing what works and being really creative and collaborative and innovative. Next slide. So in general, what we're trying to do is we're trying to break away from the historical model of tracking metrics and having dashboards and reports. All that stuff is good, but as Jonathan mentioned, it doesn't leave any time to actually do the improvement. And so what we want to do is to create a future picture environment where staff work on just one project at a time. We're not talking about creating 15 projects. You should always have one active project at a time. We like the idea of using the PDSA methodology. And then the data that you look at are the data that come out of the PDSA project. And so you're actually building improvement into the work you're doing, and that is how you yield the data that you look at. We don't think collecting numbers and generating reports is a lot of fun, but working with your peers and your colleagues to actually help your community, that can and should be a lot of fun. And we want to make the PCMH model, we want to make that as fun as possible for you. Next slide. So how do you do that? Well, the first thing is we're going to help you do an inventory of what data you are tracking and anything that's not essential to the performance of the clinic and the strategy of the organization, whether it's a standalone independent clinic or a hospital-based clinic. We're going to help you identify what to stop doing. You're probably doing too much right now. Then we're going to look at the priorities. What is going to have the greatest impact? Is it outreach to your community and helping them understand vaccinations to build the confidence? Are there mitigation and prevention strategies that should be in place, whether they're structural and infrastructure, or if it's about staff training? A lot of times the clinics, they need staff training and orientation in setting up somebody to be the COVID lead or the PCMH lead or the chronic care management lead / navigator. So what are those things that are the most important? And let's just work on those and not worry about anything else that's not really all that important. And then actually taking the time to set up, again, one project or initiative using the PDSA at a time. Don't overload the clinic with too many things. Stop doing a bunch of the work that's not particularly strategic or relevant. Figure out what's really most important, and then just work on that. And we'll help you do that. And we've got tools that are built into a program called LAKE. It stands for Learning and Action Knowledge Exchange. We're going to help you go through that process as a PCMH. And so we want to encourage you to be part of this growing community of clinics that are looking to use the COVID funding to really transform their practice. So that's it in a nutshell. And it leaves a little bit of time if we have questions or comments, but go to the next slide. Kate, I think we're done. You're going to try to wrap us up. And then maybe we've got some questions and comments. And the questions and comments can be about the material that Jonathan and Kate and myself, what we covered today. Or also it can be about the grant, because we've got Laura on the phone, and she and her colleagues there at the Office of Rural Health are responsible for making sure that all the clinics get plugged into the funding opportunities. So Kate, do you want to wrap us up?
Sure, I that was well done, and to Greg's point, we just took the opportunity with what's happening now to improve our patient-centered medical home program to make it more effective for you and less, hopefully, a little less work. And so this is just a review of the whole process when you're going through surveys. So I won't read that, but I just want to tell you about what patient-centered medical home does. This is a extremely happy ending. This is a 64-year-old homeless female with COPD, diabetes, oxygen-dependent homeless person. Imagine that. No health insurance, averaging 2 ED admissions a week, 20 admissions to the hospital a year, costing the hospital $760,000 by estimate. And this team came together. The hospital found her housing. The hospital introduced the patient to primary care physician in a patient-centered medical home. And over the next 2 years, she had 1 hospitalization and no ER visits. I mean, this is an amazing story, not just for money saving. Yeah, that's wonderful, but we're improving this woman's quality of life. It's just a beautiful story. It came from a patient-centered medical home, and I just think it's powerful story. The impact that you can have. It's a different focus. We'll talk about that later, but I do want to leave time for questions. And I apologize, I didn't get Jonathan's. One of the things that I was thinking as I was listening, this is like the triumvirate here. We each have different skills. Mine is more the clinical side. Jonathan can tell you all about the pro formas and should you or shouldn't you and what should you bill and how should you add specialists and all those good things. And then Greg can put it all together in some meaningful data that does mean something to somebody when we start having to report that, which I suspect will happen. So with that, let's take some questions.
All right. Everyone can unmute themselves, so you have that control. If you have any questions, now is your chance. Also, feel free to put them in the chat. I'll be watching the chat. But Kate, I had a quick question. Say you're a clinic and you're like, I have some of these pieces, but they're not put together yet in the PCMH model. What would step 1 be?
Step 1 would be I'll send them the standards, email me for the standards, and then we'll put a plan together. So you'll just be further along in the program when you enroll. You're just that much further along. That's for sure. Most people are already doing most of that. It's just a matter of formalizing it.
Okay.
Oh, and I spelled Lily wrong. Oh my goodness, Greg. It's Greg G. Wolf at Lily, Lily pad. You can shoot me for that one right now.
All right. I know everyone's anxious to probably jump on the next call and work on our funding right now, but
exactly. And that's important.
Well, I did record this session, and so I'll get this to my colleague as quickly as possible to get this uploaded. Please reach out to me, Kate, Greg, Jonathan, anyone, if you have questions or concerns. You will be receiving a copy of the slides. There's a lot of great information in there, as well as the recording link shortly. So Thank you all, and I will see everyone on the next call.
Thank you. Thanks so much. Take care.